I'm Mark Levis here in Chicago at the 2019 ASCO meeting, presenting an abstract on the impact of co-mutations and FLT3 allelic burden on outcome in patients treated with gilteritinib on the ADMIRAL study. So this is a study that we did sort of as a follow-up, and I should preface it with the ADMIRAL study. The ADMIRAL study is a randomized study in which patients with relapsed refractory FLT3 mutant AML were randomized to receive either gilteritinib or salvage chemotherapy, and it was strongly positive and it led to the approval of gilteritinib. However, we know when a FLT3 mutated, particularly a FLT3 ITD mutated patient presents at diagnosis and is treated with chemotherapy or chemotherapy plus midostaurin, the allelic ratio, which represents the mutation burden, has an impact on prognosis. The more you have, the worse you do. Co-mutations have an impact on prognosis, in particular the NPM1 mutations, which are quite common with FLT3 ITD mutations, seem to make the disease less bad. So the obvious question was, well, what happens in the relapse setting now that we actually have a treatment for it? Do we see any molecular features that impact outcomes? Turns out we do, but not quite what we expected. Allelic ratio remains impactful. Certainly if you're treated with chemotherapy, it's even worse. Gilteritinib is a little bit of an impact, but not much. Gilteritinib is able to overcome much of the bad effect. What we found was that NPM1 mutations were of course quite common. Half of the patients had it, but they actually made the disease worse, not better. So opposite what we see at diagnosis. Probably a reflection of tumor burden when the patients enroll on the study. NPM1 mutations tend to drive proliferation, and I suspect these patients presented on the study with a very advanced disease. We found a very unique genetic subset, DNMT3A, NPM1, so the double mutation with a FLT3 ITD mutation. If you treat that patient with chemotherapy, the outcomes are dismal, like the worst we've seen. Whereas if you treat them with gilteritinib monotherapy, the patients actually had a survival plateau that looked quite respectable. In fact, it was rather dramatic for this population. So we've defined a genetically interesting subset, DNMT3A, NPM1, FLT3 ITD mutated. A. B. NPM1 mutations don't act the same way at relapse as at diagnosis. And 3. Allelic ratio continues to be a problem. The higher it is, the worse it is.